Okay, we're going to have to get started. We're running a bit behind. So our next session is, again, Professor Wendy Bower is gracing us with her expertise. This is a session on the assessment of daytime bladder dysfunction. So if you can re-thank and welcome Professor Wendy Bower.
So how's your bladder function? It's fine. Okay. So what this session is to do is to give you some competencies in systematically approaching the child and the family of the child who has some daytime bladder issues, not necessarily incontinence. I love this phrase. This was a terrible paper, but it's a beautiful collection of words in it. It's the only good thing about this paper. The combination of an uncomfortable clinician and an embarrassed child creates an awkward and unpleasant encounter, and you won't get anywhere. So the first thing you have to do if you want to work in this area is have good child language, feel comfortable yourself talking about things that you might not have talked about, and then you'll be able to hook in the child because you're so good at it. So, if we're going to make an assessment, it's of the problem. And that just seems really obvious, doesn't it? But it's not necessarily the case. So we want to know, does the bladder empty? Is there some abnormality with the mechanics of emptying? Is there some increase or decrease in what you would expect in terms of detrusor overactivity? Does the bladder fill to what you might expect for the age? Is the bowel function optimal? So you're doing those Teflon-coated sausages every day or every couple of days? Is your defecation mechanics good? So you're actually doing sausages, not pellets? And are there any other underlying medical issues that might be contributing to this? So, as with any assessment, you need a very solid history. We want details of the symptoms that the family are coming for, but also the other symptoms that you uncover. We want a voiding history, a bowel history, the objective evaluation, a physical examination done by somebody, and we want to understand a little from the parent's point of view. So first of all, with the history, this is classic. Who's concerned? It might be misguided to think that the child that's sitting there staring at the floor is not concerned, because quite likely they are, but there are genuinely some children who are not concerned, especially with bedwetting. Somebody brings in their 6 or 7-year-old, they don't care, they're fine. You know, the person who's worried most is the family. And it's very important to know who's concerned because these are disorders where you have to work with the child, your collaborators, your detectives together, and if it's going to be one-sided, it's not going to work. So what's the big problem? And children will say what their parents say. So you say, oh, what's brought you here today? Oh, I'm really lazy with my bladder. Wow, are you? Wow, it's usually the bladders that are lazy, not the children. Oh, you've got a very special one. But they tell you what they have been told and have heard from their family. Of course, we want to know the medical history. It matters if they're diabetic and they have been for a long time. It matters if they, have nephrotic syndrome or some other major thing that changes the way the urine is produced, etc. The same with urological events, and I mentioned some of those this morning, whether they've had to have some ablation of membranes or reconstruction of a hypospadias, or they had an imperforate anus. Things that happen very early on in their life can have effects later down the track. Bowel function, it was great to listen to Frances before. One of the things that she didn't mention is, a child can have a case of worms and then go on to have bowel problems. Very basic trigger events that then start off the issues. Are there any medications that the child is on at the moment? And so many people have come up and spoken to me about kids with learning difficulties and unlabelable oddities about the way that they function. And a lot of these kids are on medication, and you should know about that because maybe it will help you in the treating of this issue. What's the family history? Particularly we know with enuresis at night time, there's likely to be a family history in a first order relative, not always, but it is likely. And we used to ask all the time about infant and toddler milestones, and then the data wasn't very interesting, so we stopped. But if there is something interesting about that child, it's good to know it. Especially if you're seeing children who have been around the healthcare system. They've seen other people, they've had investigations, they've tried different strategies. Don't think that you're offering them this fantastic solution when after 20 minutes you draw breath, they go, yeah, I did that. You need to know from the outset what they have tried and try to understand from the history why it might not have worked. I'm really interested in what's this child's adherence hook, if you like. I want to know who is this child, what are they interested in, what makes them tick, what makes them start to have a passion. These kinds of things that you can put into your treatment approach. How is it for them at school? How is it in the family? And then what do they believe about these issues? Why are they there? What has happened? And how motivated are they to be in a treatment program right now to try and do something about this? And as you can see, that alone will take a fair amount of time, 30, 40 minutes to get that kind of information. And we've mentioned this, the family history of bladder symptoms, other medical problems. We know that diabetes, you'll have more urine. We know that after a long time of having diabetes, you'll have less contractile force in your detrusor. We know that ADD or ADHD is all about your relay stations being a bit numbed down. We know things like enlarged tonsils, adenoids somehow change the oxygen uptake at night time and are associated with anuretic episodes. And we know a little bit about depression in children, but not as much as I'm sure there is to know. Now, I'm a big believer in outcome measurement. If you want to say that you have made some positive gains with this child, you better know what they were like first. So you better make some measurements that are reliable and robust. And in terms of incontinence, you can measure it in two ways. How wet, so the amount, which is a little difficult, but you can do it, and how often. We get severity muddled up. Is it the number of times you're wet or how wet you are? There are two parameters. If it's nighttime wetting, we will measure how wet you are by having a dry diaper at nighttime. We know the weight of it, and we weigh it again in the morning, and then we add on the amount in mils that they void in the morning. And we make the weight equivalent to mils, and we have an idea of their urine production overnight. And that's a key parameter in managing enuresis, because you will either reduce the amount of urine or you will increase the size of the bladder, or you will arouse. So in terms of that symptom, we can measure it. We don't really do pad tests on children, especially in routine clinical practice, but it's easy to use the severity indicator. We had a tool called the dry pie, and you would know whether the worst thing that happened to you that day was dry, damp undies, wet clothes, or wet socks. And you could colour this in a different colour, and then you would be able to, it's been tested for reliability, and it's a valid, robust measure, even though it just looks like a fun thing to do. And you can actually say, in the last 2 weeks, there was this many of whatever severity versus how it was to start with. So that's one example of how you would measure it. But a bladder diary might do the same thing. We want to know whether the wetness itself was at urge, or whether it was during a physical activity, because we want to know whether it's overactivity of the bladder or whether it's lack of being able to accommodate increases in intra-abdominal pressure. Is it a particular time of the day? Not all accidents are pathophysiological, if you like. You take a kid who maybe went to the toilet at the beginning of lunchtime at school finishes at 3 or whatever, the bus is right there, no time to go to the toilet, you're an hour on the bus over bumpy roads. Is that pathophysiological incontinence? Not really. So that kind of thing, you'll pick up straight away in the assessment area. I know how to sort that out. You go to the toilet 5 minutes before school finishes and you'll be fine. What about post-void? As I said, there's that small proportion of vaginal reflux children you might see. The stool habits, and as Francis said, it's so common to see onset of bowel problems when they start school, when they start a new routine, when they no longer can do that postprandial sit in the morning, they're rushing off to school or taking a long time to travel, etc., or not using the school toilets. And what are the attitudes around bladders and voiding at school? I'm sure you all heard, I think it was last year, of a principal at a Victorian school who got into all sorts of trouble because she decided that the whole class should be toileted when one person wanted to go, and all the children were being marched out to the toilet all the time. But it's quite common in most schools that you have to take someone with you to go to the toilet. So how does that make you feel if you want to go and you go often? It's very uncomfortable, isn't it? This is a visual analog scale that's also been tested for reliability and is robust. And this is a way to measure urgency at the beginning of treatment and after different interventions. And so you simply ask them to put a slash through the line at what it's been like for them the last few days when they needed to go to the toilet. They could make the urge go away, so they don't really have urgency. They could easily hold on, they could wait a little while, they could hardly wait, or they could feel the wee coming out. And this has been shown to actually change. You measure it, then where the line is, it's a multiple of 10 centimetres, this line. And you measure it and you have a number, and the number changes with successful treatment. And this is a robust outcome measure. And then these other things you're going to get from a frequency volume chart, which we'll talk about later. And you're asking about these fundamentals of toileting. Right. Somebody has to make a physical examination of the child. You might not be the person who's competent to do this, but somebody has to do it. You can learn how to feel a bladder, and you can learn how to feel lumps of poo, and you can learn how to palpate the descending colon, etc. But you might never be very good at rectal examination or checking perineal sensation, and it might not actually help you to build a good relationship with the child if you're the person who does this. You need a team, and you need to know that somebody will take care of doing this physical examination and the inspection of the genitalia, etc. Somebody also needs to do the neurological assessment. As it was said before, you can often see these skin changes and things over the lower spine, but not always. You can often, if you're really good at movement science, you can often pick up unusual aspects of the gait and symmetry, but not always. Now there are 2 pediatric symptom scores that have been developed. In my opinion, neither of them is the ideal one, so if you have an interest in developing a new symptom score, then by all means you probably should. These ones don't include the bowel symptoms, and they miss a few other points, but nonetheless they're there, and they give you a number at the start of treatment, and you can generate a number anytime during treatment. But the most common measure that we use to understand what's happening with bladder function is the bladder diary, the full bladder diary, so the one that goes for the 2 days minimum. And I like to introduce this in person rather than send it in the post and say bring it back when you come for your first visit, because there are many ways to confound the data on this diary. And if you can sit down with a child and engage them as your co-investigator and your detective and let them know that you know the tricks, like, I know when kids fill up the jug with tap water. I know when they write all the entries in the same coloured pen. I know the tricks for this diary, but really it has to be like a movie of how you're using your bladder, so we can try and work out what the problem is. And if you have the opportunity to introduce it like that comprehensively and go through the way you actually have to do it, I think the data you get is more sound. If you're using the data for an outcome measure, then you need sound data, don't you? So we can find out from this 2-day bladder diary how much urine they're passing in the day and at night. We can find out when they're wet. We can find out if they have arousal, they get up to void at night time. If they void anyway without waking. We can find out if they have polyuria, so how much urine they make overnight. And we can get an idea of their fluid intake. Fluid intake is important because you might be having someone who's dehydrated, and this sets up the system to be much more sensitive because the urine's concentrated, and it also helps them along the road to constipation if they're not having enough to get by on. I just would say here that a long time ago we used to think that if you just pushed a lot of fluids you would make everyone better. People aren't wet because they have not enough fluids, so they won't be dry if you give them more. We have moved on from there. It's part of what you might need to implement, but it's not at all the sum total. It's not a monotherapy. So the bladder diary, we would like it to have 3 nights. We would like them to measure in a jug, not to guess. Go to great pains to explain that there's no right and no wrong, and I'd like that before they completed it, not after. And here's can you read this? Yes, you can. Tell us what it says.
This is from a hospital.
Yes?
In Pediatrics.
Yes?
And how much is your delivery frequency and volume?
That's right, she's right. So this is the one we used in Hong Kong, and so it's telling us when the child drank and how much, and when they voided and how much. But as I said, there's lots of confounders to completing this diary, and if it's a large family that the child is in, it's likely that it won't get attended to in the way that you want. There are many sources of error that I've mentioned to you. It doesn't tell you if the voiding mechanics are normal or not, and it doesn't tell you if the bladder emptied at each time that the child voided. And there's a massive variability. We tested all the parameters, or I think we had about 330 of these charts, and they were over 7 or 9 voids or something. And massive variability by age and the amount that you voided, and the voiding interval was the most variable parameter of all of those, because we can go at will, and we do go at will. Sometimes we go just in case, and sometimes we hold on and we hold on and we hold on, and kids are like that too, so bear that in mind. We see this variability in normal kids and kids with problems. So from the diary we can understand the voiding frequency of that child on that day. We can get an average of the volume that they stored, and then the maximum volume. When do you think you have your maximum volume in your bladder? Yes, when you're not having the effect of gravity, so it's usually the first morning void. So mostly we remove that first morning void from our calculation of the average bladder capacity because it's a little bit skewed. We can, as I said, have the overnight urine volume to see whether there's polyuria, and we have an idea of the fluid that's going in. In very, very young children, or maybe children with disabilities, you can do an intensive 4-hour observation to get an idea of the bladder behaviour. But again, you don't really know what is the interaction between filling and emptying and what the mechanics are like. If you've got any concerns about the bowel, you need a 14-day bowel diary. And why do you need one that's so long? Because some kids poo twice a week, and so you need to have enough events to be able to measure it. You know, if we talk in epidemiological terms, you know, you have to have the event and you have to have exposures, and you can't know this if you've only got a few events. So we can tell from that what the stool quality is like, the frequency of defecation, if there's any fecal incontinence. Neither the bladder nor the bowel are very good witnesses. Self-report is a disaster, especially in children, but it also is in adults. So you need this objective measure, real time, at the time, somehow it's documented. And you've seen this Bristol stool scale, which is very nice. But you also want to know if the bowel action was spontaneous or the child was sent there by the mother. If you've got me as your mother, you're sent to the toilet after your dinner. So your therapist would want to know about that to start work on me. How does the stool look? Is there any pain when you're passing it? Is there any bleeding? Children get hemorrhoids too, children get fissures, children, as I said, have discomfort passing stool. If they're watching a movie or something that they can't stop, they can ignore the call to stool. And you want to know these kinds of things. We also have some quality of life measures now. We have a thing that we developed in Hong Kong during SARS when we couldn't treat children. We developed a Pediatric Incontinence quality of life tool. We got all the people who were treating children around the world to help us collect the data, and then we made this tool that you can use to find out if there are certain aspects of the bladder problem that are interfering with the quality of life. And it's a robust tool and it changes with intervention. There's also the child behavioural checklist for some behavioural screening, and there's a short form of this that comes from Ghent in Belgium, which is really good for using. It's just, I think, 12 questions, really good for using as your first assessment battery to see whether you need to involve someone like a psychologist to help you with this child. We know for sure that if there are behavioural issues that you can identify on these screening forms, that your therapy will be less effective, because you need to work with the child and they may not be able to because of some of these behavioural issues.